Good evening, everyone. Thank you for joining us on this very cold, wintry night. Well, at least it is here in Hamilton. My name is Christine Kennedy, and on behalf of the Office of Alumni Engagement and the McMaster Optimal Aging Portal, I'd like to thank you for joining us for yet another talk in our Optimal Aging webinar series. Tonight, we are thrilled to have Dr. Dawn Bowdish from McMaster's Faculty of Health Sciences give a talk on how vaccines play a role in healthy aging and can reduce the risk of dementia and other conditions. Before I turn the mic over to our moderator for this evening, Dr. Anthony Levinson, I would like to take this opportunity to acknowledge that the land on which McMaster faculty, staff, and students learn and work is on the traditional territory of the Haudenosaunee and Anishinaabe nations. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and the Ojibwe and allied nations to peacefully share and care for the resources around the Great Lakes. As always, we are thankful for you taking time out of your evening to join us. Just a reminder that this webinar is being recorded and you'll receive an email with a link to the recording later this evening. And feel free to share that link with others, family and friends, about all the information that you're learning this evening from Dr. Bowdish. So if you have any questions, thank you for those who pre-submitted their questions. But if you have any questions live, feel free to type those into the Q&A section. So now, as always, Dr. Anthony Levinson will be taking over the webinar. For those of you who don't know, Dr. Levinson is both a professor at McMaster University and a physician who works in the area of consultation liaison psychiatry. He is the director of the Division of E-Learning Innovation in the Faculty of Health Sciences and is part of the leadership team for the McMaster Optimal Aging Portable. Thanks, Anthony, and I'll hand it over to you to introduce Dawn Bowdish.
Thank you so much, Christine, and thanks everybody for joining this evening. Really excited about today's webinar. So also want to thank everybody for sending in the pre-submitted questions because Dr. Bowdish has had an opportunity to incorporate those into the talk, and then we'll have an opportunity for some additional Q&A later on. So pleased to introduce Dr. Dawn Bowdish, a professor in the Department of Medicine here at McMaster University, also the executive director of the Firestone Institute for Respiratory Health, a member of McMaster's Institute for Research on Aging, the Immunology Research Center, and the DeGroote Institute for Infectious Disease Research. Dr. Bowdish has a Canada Research Chair in Aging and Immunity, and her research on aging, immunity, infection has appeared in over 180 peer-reviewed publications. She leads the Bowdish Lab, and I'm also proud to say that she was recently honored with Research Canada's Leadership in Advocacy Award. So she'll speak for about 35 minutes, then we'll have an opportunity to do some additional Q&A. And with that, I will turn it over to Dr. Bowdish. Thanks so much for joining us tonight.
Thank you so much. Thank you for this kind introduction. Thank you for allowing me to be here and speak tonight. And I just wanted to say, in my field of talking about vaccines and infectious disease, it's an area where there's just so much misinformation. So to be able to be here at the Optimal Aging Portal, which I consider one of the gems of McMaster for providing good evidence-based knowledge, and to be with people who seek out that knowledge and who are using this portal to seek out the best information on this, it really means a lot to me. So there is nothing I would rather be doing than spending this time here with you. So to get started, today I'm going to talk about an idea that's been sort of percolating for the past 20 years, but we now have really strong data to suggest that dementia may actually be something we can help prevent by vaccination. But before that, I'd like to tell a story. So I'd like to tell you the story of William Ottermolen. Now, he was an artist, and like many artists, he experimented a lot with portrait drawing and self-portraits. And although he maybe was not the kind of artist I would hang on my living room wall, you can admire some of his portraits to see how he was a particularly creative artist who participated and used a lot of different mediums. So these are a series of his self-portraits he did of himself, and you can see some of the interesting artistic choices. So if you look at the youngest one, tons of detail in the hands, and they're sort of oversized and not very much detail in the face. So he's very experimental. I particularly like this one of him at 24 years old, because remember, we were all that young and skinny. His wife's favorite was this portrait of him at 34 years old, and he started experimenting with mixed media when he was in his 40s and 50s. But something happened to him when he was trying to paint the portrait of him holding the mug. And the thing that he found difficult is he was having a really hard time getting it to look the way he wanted it to look. And so in the end, he drew the mug over the face to sort of conceal the fact that he was struggling to get the picture just right. Now, his wife was an art critic and an art historian, and also probably, like all good wives, one of his biggest fans. And so she was also a person who he often did these portraits of, and you can see a portrait sort of earlier in the relationship and later in the relationship there. And at around the time that he was struggling to get this portrait just right, she had noticed that there were some changes in his ability to get proportions right, which is particularly problematic if you're an artist. So this would be an example where you could see he was doing a sketch of a drawing of a person, but the legs aren't quite in the right space. And at this time, he was also having some other behavioral changes that she was worried about, not being able to tie up his tie and sort of forgetting some basics. And so, on her insistence, she had him examined by a neurologist. And the neurologist also identified that he was losing his ability to get things in the right proportions. And apparently, when the neurologist asked him to do this drawing, he could tell that there was something wrong with the arms, but he couldn't tell what exactly it was, and he couldn't figure out how to fix it. And indeed, in his portraits of Pat, his wife, that he did after this, you see that he loses some of the complexity in the art that he was doing. Well, as it turned out, he was diagnosed shortly thereafter with Alzheimer's disease. And his first portrait that he drew after he got his diagnosis was one of him looking lonely and sad. And when he was asked about it, he says that he was looking up the sky and dreaming of getting out and leaving that diagnosis. As his mental state declined, he was encouraged to continue painting and drawing, and sort of as a way of both keeping him engaged, but also helping him reinforce his identity as an artist. But all the paintings and all the drawings that he drew after this point really capture his sadness at this diagnosis and his fear. And you can see that by the time he was 64, he was really losing the ability to capture some of the depth of the portrait. And indeed, in his portraits where he was declining, his wife described that he would just erase them again and again and again because he could tell that there was something that wasn't quite right about it, but he didn't know how to fix it. And by the end, the last portrait he drew was that one in 2001 that you can see on your screen, and you can see it's barely a face at all. I find his art and his story absolutely haunting, because it really describes to me the scariest part of dementia with age. It's not just about losing your abilities, but it's also about losing your identity. And he really captured the sadness and fear of this. And if you're here today, it is probably because you too worry a little bit about dementia and what that would mean for your aging. There's lots of really great evidence-based things that we can do to help prevent dementia. You got to eat well, don't drink too much, take care of your hearing and your eyesight, be a lifelong learning, so you can all check that off your box because you're here right now. Exercise, socialize. We're social animals and we need socialization, and manage those health conditions. All these things sound so easy, but they're all so hard. We all know what we're supposed to eat, but the fact of the matter is junk food tastes so good. And I can say this as a woman who stands before you with a deep love of the potato chip. And it's also a lot of work to cook, especially if you're cooking for one, if you're managing other health issues, if you have a busy life. The dictate that we should all socialize because that's good for our aging brains. Well, it's hard if you've lost a partner or your social groups become a bit smaller. We're also in the middle of a loneliness epidemic. And so managing all these things actually takes a lot of sustained effort. And if it was easy to do, we would all be doing it. So my proposal to you is there's something that I think comparatively is a lot easier than doing those other things, because it might involve a trip to the pharmacy, maybe an afternoon of not feeling so hot, but does have an impact on one's risk of developing dementia. And I'm going to walk you through the science behind this. So I've just told you a sad and scary story about an Alzheimer's brain, one that is so shrunken and degraded that you can actually see it on imaging like this. But in science, we don't just learn from extreme examples of things gone wrong. Sometimes we can also learn a lot from examples of things gone very right. And so now I'd like to tell you a story about someone who's had the opposite of experience of William Ultermohlen. I'd like to introduce you to two supercentenarians. So a supercentenarian is someone who lives past 110. If you live past 100, you're a centenarian, but if you live past 110, you're a supercentenarian. And the interesting things about supercentenarians is they don't seem to develop dementia. So the woman in the white dress in the first photo there, the one who's standing, is named Hendrike van Andelschipper. And she, very briefly, was the oldest woman in the world. She was interesting in many ways. Like many supercentenarians, she wasn't a particularly privileged person who lived a life of luxury. And in fact, many supercentenarians ended up having jobs that required a lot of physical effort in sort of midlife. And that's thought to sort of protect them and build some muscle mass. She was actually born premature, and which is, especially back then, was a bit problematic. But the other thing that's quite remarkable about her is she, of course, lived through the 1918-1919 influenza pandemic. And indeed, she lost two brothers to that pandemic. And one of the interesting features about these supercentenarians is they often seem to have survived, especially influenza, at a very young age. And there may have been some specialness about how they sort of dealt with that infection, because they very rarely die of influenza or pneumonia in late life. Let's meet Maria Brañas Moreira, another person who was very briefly the old, or not so briefly, I think she had a few months in the position. She was also one of the oldest people in the world. Now, she was Spanish. Her family lived in America part-time. We know she would have been exposed to the influenza pandemic because she was born in that time frame. What we don't know is whether or not she had it or was documented to have it. But her father did die of tuberculosis, and she never acquired tuberculosis. So there is some thought that she too seemed to have a little bit of resistant to infections in a way that may have been beneficial. What's remarkable about both these women is they donated their bodies to science. And so we've learned and are continuing to learn a lot from what they've donated. Like many supercentenarians, they also seem to have lower levels of inflammation than we would expect. So the two things I want you to retain from this is that they seem to have been exposed to and had particularly unique or maybe resistant immune responses to infections, and they seem to be lower on the levels of inflammation than one would expect. And they don't develop dementia. That's another key point. So these sort of observations about the very, very long-lived and people who live without dementia were sort of the seeds that started an area of research about how inflammatory events can contribute to and accelerate to dementia. Now, I've heard this story from so many caregivers of people who are caring for people with dementia that I don't think it'll be too surprising to many of you if that's the position you're in. But oftentimes, people who are living with dementia, when they have an inflammatory event, so it could be a surgery, could be a heart attack, could be a fracture, could be an infection, anything that causes a big bout of inflammation, they often have a decline in their cognitive capacity. And even when that thing goes away, so they get better from the surgery, the broken hip heals, the infection goes away, they don't get back to the level of cognition that they were at. And as they have more and more of these events, you sort of feel this declining capacity. And one of the earliest researchers who sort of pioneered this field had the hypothesis that these big bouts of inflammation that come with one of these major events may be something that interacts with the brain and it causes dementia to accelerate. Research in my lab focuses on the relationship between infections and especially respiratory infections and dementia. So for decades now, there's been this observation that when people who are middle-aged or older go to the hospital for a serious respiratory infection, they seem to have an accelerated rate or an increased likelihood of developing dementia. And indeed, this is some data from a colleague of mine for a project we were working on, Christopher Schur at Health Sciences North Research Institute, where here he was looking at people who were hospitalized for either a fracture or a pneumonia, and then following along to see how long they lived without getting a dementia diagnosis. And as you can see, the people who get pneumonia are more likely or more rapidly acquire this dementia diagnosis than people who have a fracture, even though both these things are big inflammatory events. This, although this is our data, this has been published by many, many other groups in a similar fashion. There seems to be something uniquely problematic about the kind of inflammation that comes with an infection, and respiratory infections are the most common infections that older adults are hospitalized for. Whatever the special feature of the inflammation that comes with infection, it seems to drive this dementia risk even more than surgeries or fractures or other inflammatory events. And here's a visual of some data that sort of quantitates this. So here, if we look at the date a person gets a dementia diagnosed, and we look at infections 1 year prior, 5 years prior, or 15-year prior, and we break it down, we can see that having had an infection a year prior does seem to accelerate the rate of dementia diagnosis, and in some cases, by a lot. So viral encephalitis seems to increase the risk the most. And this kind of makes sense because a viral encephalitis is literally an infection in the brain. And so you can imagine all that inflammation in the brain itself could be a driver of dementia. But other infections, influenza, other viral infections, or we often group influenza and pneumonia together if we don't really know what the cause was, are also associated with this increased risk of dementia. And it doesn't have to be a super recent infection. So if we look back at the 5-year mark, the risk is lower for sure, but it's still there. So having viral encephalitis is still the absolute worst, but having influenza, other viral infections, or pneumonia still increases that risk. Now, this slide makes people paranoid because we've all been sick and we're all worried that that's going to lead to dementia. But I want to point out 2 things. You have to be so sick that you end up being hospitalized for this to increase the risk. And you can stop worrying, if you had an infection in your childhood or many, many moons ago, because we can see that the risk is quite low for infections that happened 15 years prior. Now, here I've shown you all-cause dementia, but the numbers and the risk is similar for all the various kinds of dementia. So the body of data suggesting infections increase the rate or increase the risk of dementia is really quite immense. It stands to reason that if we prevent these infections through vaccination, we might reduce the risk. Surprisingly, the body of this data has been really slow to accumulate. So this is a graph I made sort of roughly estimating types of vaccines that have been associated with protection from dementia, and from really strong evidence to weak evidence and big protective effect versus small protective effect. And you'll recognize many vaccines that you've probably had and a couple that you probably haven't had. And as we go through the talk, I'll sort of break down some of the science for each of these vaccines and the theories about how they're protecting from dementia. We don't have the definitive answer yet for how vaccines prevent from dementia, but we've got two really strong theories, and I'll walk you through where we're at right now. So the first theory is that vaccinations prevent infections, and those infections cause inflammation in the brain, which is bad for the brain and increases the risk for dementia. Let's review that evidence. Now, the eagle-eyed amongst you will see that the infection that we have the best evidence for and seem to have the biggest effect was the shingles vaccine. So shingles vaccine is caused by the varicella zoster virus, and common name is chickenpox. So all of you got chickenpox when you were young. And when you got chickenpox, you got real sick and you felt real poorly. Then you got better and you thought it was all over. But in truth, it's not all over. The virus that causes chickenpox hides out in nerves and can reactivate later in life, especially if we're really stressed out, if we're immunocompromised, or even as we get older. And it can cause this really, really painful condition called shingles. And you can see a picture of it right here. Oftentimes when I do a talk in person, I ask the audience, who here's had shingles? And then I say, of you who've had shingles, who thinks that everyone should get vaccinated for shingles? And they all put up their hands, because shingles is an incredibly uncomfortable and very difficult to treat condition that can make people's lives really, really difficult. So it's a great idea to get the shingles vaccine to prevent shingles. But there's also some data that it also helps protect the brain. So this is one study of a number of studies which looked at 100 million people in the US by looking at medical records. And it looked at people who had repeat bouts of shingles, people who had more than one bout of shingles, and it compared them to people who only ever had one bout of shingles. And it found that in the 3 to 9 years that followed, there was a 7 to 9% increased risk. Now, in this particular study, they didn't compare no shingles to just one case. They looked at one versus more than one case. And that's, in 3 to 9 years, a pretty substantial increase in the risk of getting dementia. So that sort of sets the stage that shingles can be associated with this dementia. And the thought, of course, being that it causes a very strong inflammatory response. So the next logical question is, if we get vaccinated to prevent shingles, can we also prevent that increased risk of dementia? This study is extremely clever for the way it was designed, and was a really clever way of sussing this out. So this looked at some British data for when the first shingles vaccine became available. And so if you were born before September the 2nd in 1933, you were never eligible for a free shingles shot. They just didn't offer it to people who were born before then. So unsurprisingly, very few people got vaccinated, 0.1%. If you were born the next week, you became eligible for a free shingles shot. And there was a big campaign to try to get older adults to get their shingles shot. And unsurprisingly, about 47 people took up their government's kind offer and got a vaccine. So this study said, if shingles vaccine prevents dementia, then the rate of dementia should be lower in the people who were born in this week, as opposed to the people who were born in that last week of August. And I like this study a lot because it's comparing people who were born, just 1 week different. And so there's no real other differences between those people. There's no difference in other health conditions, or there's no difference in sex distribution or where they live or any other factors, really. It's just comparing people 1 week for another. And what they found is, in the folks who got that shingles shot, there was about a 20% reduction in dementia, which is big, really, really big. And so this was a really compelling piece of data suggesting that shingles vaccine does indeed reduce dementia. And since the studies come out, other countries have replicated it. So there's a similar study in Australia where they did the same thing. They picked all the people who were born the week before you could get a free shot and all the people born the week after, and they found a similar rate of reduction. And other groups have done it in slightly different ways, but still finding the same thing. If you compare people who are really closely matched, those who had access to the free shingles vaccine seem to have less dementia. But shingles doesn't really live so much in the brain. So the theory was, you get these shingles reactivation, there's a lot of inflammation, you prevent that inflammation, you protect the brain, it's good. There is a second theory about how this will work. And the data is not quite as strong, but it's an interesting idea. Now, herpes simplex virus, or the cold sore virus, if any of you have ever had a cold sore, is a very close relative to the virus that causes shingles. And unlike shingles, the nerves that the herpes simplex virus likes to hide in do include parts of the brain. And for a couple decades, there's been this theory that being a person who naturally has this cold sore virus and carries it with you does increase the risk of dementia. But it's been extremely controversial because almost everybody carries that virus. And so it's really hard to disentangle between people who do and people who don't. Now, there is good evidence if you can sometimes get a sickness with this herpes simplex virus 1, where it's a systemic illness. Now that, in contrast, if you get that, you do seem to have an increased risk of dementia. So the data for that is moderately good. And so someone said, maybe if we just give healthy people a drug that you give to people who have cold sores, who have this serious herpes simplex, does that decrease the risk of dementia? Now, in science, we never get excited about one study. We have to have replication before we accept something as true. But in that one study, they did find people who were taking these anti-herpes drugs did seem to reduce the risk of dementia. So now there are some people who think that perhaps getting the shingles vaccine actually also helps protect a little bit against this herpes simplex virus because they're so closely related. The jury's still out, but it's an interesting idea, and it gives us scientists something to keep us busy as we try to figure it all out. So that sort of explains herpes and maybe the shingles viruses. But the vaccines that also are associated with preventing influenza, pneumonia, and RSV are also associated with some of this decreased risk in dementia. And how might that work? Well, the thought is that they may work the same way, or they may each work in subtly different ways. So the bacteria that can cause pneumonia can in fact damage the brain. It can go and live in the brain. Whether that happens in people who get serious pneumonia or other infections with that bacteria, and whether that's the cause of dementia, is a little less unclear. Jury's still sort of out about the COVID vaccine, simply because we haven't had enough time to do those studies where you see if somebody who gets vaccinated develops dementia 3, 9, 10 years out. But we do know that serious infections can cause brain-harming inflammation. We also know that, at least in mouse studies, when you give a mouse influenza, it causes brain inflammation. So the thought is that these other vaccines may have their protective effects because they stop the infections that have this really strong inflammatory response, which is bad for the brain. And what's interesting is that older adults seem to have slightly delayed inflammatory responses when they get sick, a little bit slower to get started, but sometimes they're actually more dramatic than younger people. And they take longer to resolve. So it takes longer for that inflammation to go away after you get sick. And the theory is that, we have these strong inflammatory responses, but if they don't go away, then you have a little bit more of that circulating inflammation that's higher than when you started. You get another event and it's higher and higher and higher and higher. And soon it pushes us over the threshold into getting dementia. So the theory is that by preventing these infections, we prevent this inflammation from building up. And that's maybe what protects our brain. So to summarize this part of the talk, the vaccination prevents infection and harmful inflammation. This makes total sense for vaccines like shingles, pneumonia, influenza, RSV, and possibly COVID, but it makes a lot less sense for these other things. So the data is not nearly as strong for these other vaccines as it is for the ones in the left column. But as an example, the BCG vaccine, which is used to protect against childhood tuberculosis, is also used as a treatment for bladder cancer. It's actually literally injected into the bladder, and it kicks the immune system into gear and helps fight that cancer. But it doesn't protect against like tuberculosis or anything like that. So it's not stopping an infection. It's actually being used to stimulate an immune response. Similarly, there have been associations with rabies vaccination and lower rates of dementia, but people who get rabies vaccines are like people who work with animals or, vet techs, those sorts of people. They don't actually get rabies. So it's not that we're protecting against the rabies infection. Diphtheria and tetanus, we should always keep up with them, but very few of us get that. And of course, very few of us get polio. So for these vaccines that still seem to have this weaker, but still protective effect against dementia, how could they work? Well, the theory is that these vaccines actually help sort of boost the immune system. There's 3 ingredients in all vaccines: the antigen, which is what you're making an immune response against to; the adjuvant, which tells the immune response to, or the immune system to respond and sort of kicks it into gear; and of course, the preservatives to keep it safe. And the theory is that the adjuvant might have this immune boosting activity. And so one of the recent papers that sort of investigates this looks at the protection from getting the shingles vaccine and the RSV vaccine. Very different vaccines, but they have that same adjuvant, that same immune booster. And so in this study, what they find is if you get either your shingles or your RSV vaccine, you get about the same protection against dementia. And they conclude that this is more likely to be due to that adjuvant or immune booster than the infections themselves, because that's something they have in common. And furthermore, you can't stack and add up your vaccines to get to 100% protection. So if you get the shingles and the RSV vaccine, you don't get any more than that 18 to 37%. So it's not, they theorize it's not so much about preventing the infections in this case, but this adjuvant immune building property. Now, this is still very much a theory and needs a lot of additional investigation to get to the bottom of, but it's really quite intriguing. And this might explain the mechanisms for other vaccines like the BCG, tetanus, diphtheria, pertussis, rabies, and polio, where the vaccine still seems to have a smaller but still protective effect, but is unlikely to be because it's actually preventing infections. So a very reasonable question would be, okay, this is great news, Dawn, but what about if I already have a diagnosis of mild cognitive impairment, or if I have an early dementia diagnosis? Should I get vaccinated to help protect from that? And again, the data does suggest that for the shingles vaccine, this is the case. So the theory is that you get this vaccine, you reduce those inflammatory events by preventing these, the shingles or anything else, and it does seem to slow down the progression from dementia. So in this study here, they showed, basically if you're a healthy person, you get your shingles shot, you're less likely to get dementia. If you have mild cognitive impairment, you're less likely to progress to dementia. And if you have dementia, you're less likely to die of dementia. So moderates the disease course. This is the only study I know of at this point that's investigated this. So we still need replication, but it's consistent with the other data that I've shown you so far. So now I've convinced you all, we're all running out to get our vaccines because we all think this is a fast and easy way to help us protect our brains. The question of when is completely not resolved. I don't have a good answer for when, because we know that transition from having a healthy brain to having a brain that has Alzheimer's or other dementias is actually a slow process. It starts 10 to 20 years before any symptoms emerge. So there's 2 schools of thought. One, we get all our vaccines as early as possible to give us the most protection, Or possibly, should we give it when we're most vulnerable? Which would be better? Well, we don't really have good data to support this in either way. But one study has investigated the permanence of, like, how long does the shingles vaccine protect you for? And what's intriguing is that protection from shingles lasts at least 10 years and quite possibly a lot longer. The protection from dementia seems to fade by 10 years. So this, if this is reproducible, this would be a case to get repeat vaccines to do that. Who benefits the most? Should everyone do this? Should we all be running out right now? Well, it's actually quite intriguing because many of these studies, not all, but many of them, find that almost all the protection for the shingles and dementia is in women. So women's brains seem to be either especially vulnerable to the shingles infection or particularly boostable by the shingles vaccine. Again, not all the studies find this, but many of the studies, women get the most benefit from this. And in one study, they said they try to ask this question about, should we get it when we're 80, which is when most dementia diagnoses are, or should we get it younger to prevent? Unclear, but in this study, they identified that at least for the influenza vaccine, younger seem to have a bigger benefit than older. So maybe earlier is better than that. In either case, our vaccine recommendations are not set up for dementia prevention. They're set up to prevent from infection. So these are what the current recommendations are for adults in the province of Ontario. Ontario is one of the more generous provinces with getting vaccines. So if you're from a different province, you might have different availability. But we have some quirkiness in our vaccine schedules. So for example, if we look for when the shingles vaccine is covered for free, it's only between 65 and 70. If you want to get vaccinated outside that, you have to pay for it out of pocket. And for some of our other vaccines, you can get them at any time, but some of them, they have sort of very narrow coverage periods. And so an ongoing research question is, if we expanded these or changed these, would we get more of these off-target effects of preventing from other health conditions like dementia? So with that, I'll finish up so that we can have lots of time for our conversation. I just want to acknowledge my lab. One of the projects we're really actively pursuing right now is uncovering why and how infections lead to cognitive decline, and we're trying to find novel ways to prevent that in our mouse models. We also do a lot of studies of vaccination in older adults and are trying to understand differences between men and women in our responses to infections and vaccinations to try to help us understand some of these observations. So with that, I would love to have time to have some questions with you.
Well, thank you so much, Dawn, for that really insightful presentation and a really interesting mix of different study methodologies as well as impactful stories. So we did have a large number of really thoughtful questions in advance, and they kind of cluster around a few key themes: which vaccines to prioritize, how strong the evidence is, how vaccines might protect the brain, which you talked a little bit about, who might benefit the most, and what this means for people who might already have memory changes or dementia. So I'm going to start with some of the more common ones. One of the biggest ones was sort of a practical one, and you did highlight like the Ontario vaccine schedule. But let's say somebody is 65 or older, generally healthy. Which vaccines do you think they would or should prioritize to help lower their dementia risk, and how often do they need them?
Yeah, that's a great question. The data is strongest for shingles. And so the data suggests there, okay, so I'll preface this by saying, get all the recommended vaccines because you don't want to get sick. So putting dementia aside, it's, you don't want COVID, you don't want influenza, you don't want RSV, you don't want any of those other things. But if we were thinking about this just from the lens of dementia, shingles vaccine is the one that has the strongest evidence for it. And it's a 2-dose one. So you'll need the 2 doses to be completely protected. Like I said, in Ontario, it's only paid for between 65 and 70. So I think if you're of that age group, and it's recommended for anyone in that age group. But if you're undergoing like cancer immunotherapy or immunosuppressive drugs, or there's some other health conditions, your doctor may recommend that you get it before you start those, just to help to make sure you don't get shingles during that case. So I think the data for dementia is strongest for shingles for sure. After that, we move into influenza as being one of our ones that has an increasing body of evidence. And for that, there's some interesting observations. One is the more vaccines you've had over your life, the more the dementia risk seems to decrease. So get in the habit of getting that flu shot once a year. Now is an incredible time to do that because our flu season in Canada has started earlier than it normally would, and it's particularly severe. So 2 great reasons to get that. And then after that, we don't really have strong data for COVID vaccines yet, more because we haven't had enough time to really pull out the dementia risk. But again, COVID in and of itself, if you're older, is worth preventing. So that's a good one to get. And we're really learning how bad RSV is in older adults. It's an interesting sort of cautionary tale in that we didn't used to do, in the pre-COVID era, we didn't used to do like a lot of testing for RSV. So if an older adult ended up in the hospital with serious respiratory infection, very common not to know what they actually had. And when those tests started happening and we were able to start documenting, it became apparent that having RSV was associated with health issues post RSV. The data is still not super strong for dementia. It's very strong for heart attacks. But we're increasingly learning that RSV is probably something older adults should really try to prevent. And my hope is that we'll actually expand the vaccine recommendations for that because the data emerging is really very compelling. The pneumonia vaccine, we've known for actually decades that there's this link between reduced heart attacks. The data is less strong for dementia because the pneumonia vaccine doesn't prevent all pneumonias, so it's a little bit hard to tease apart. But certainly that's a good one to get to protect hearts and to protect lungs and to protect, likely, although not absolutely, to protect the brain.
Yeah, that's great. I'm going to ask a couple follow-ups. Just one is more for definitional clarification. Somebody was saying, how old are the older people or wise folks? And when you talk about older adults in some of the studies or middle age, just to kind of hone in on what studies are usually referring to.
Yeah, so some of the questions, like that one in 1933, everyone was sort of 80 by the time that the study was actually done. So that one was really looking at really late life. And what's been one of the challenges of doing studies like this, if you vaccinate everyone today, you've got to wait some time for them to develop dementia. And if you do this at 50, you've got to wait a few decades before enough people in your study have got developed dementia. So many of them sort of wait it towards 70, 75 plus or 80 plus, because then the amount of time they have to monitor is a lot shorter. So what we really need to figure out, like when we should get vaccinated and how far advanced, is like bigger longitudinal studies with a bigger time course. So most of the studies are 70 or 75 or 80 plus. So they're at the later and not so much at middle age. And like I said, this leaves a huge knowledge gap because we know dementia, actually the seeds of dementia start decades earlier. So would we be better off trying to prevent by vaccination in one's 50s or 60s? The data,
even earlier, the biomarkers.
Yeah.
So that's great. I also do want to just re-emphasize that, tonight's talk and our conversation is really about the science around this and for education reasons, and it doesn't constitute medical advice. So if you have concerns or questions about your own health and whether you should or shouldn't get a vaccine, important to discuss that with your healthcare provider. But we'll try and outline the science of it. So there were a couple of follow-up questions related specifically to the type of shingles vaccine, and does it make a difference if you have had the Zostavax versus the Shingrix, and don't know whether there's enough data to tease that apart or not.
Yeah, that's a great question. So that study about the 1933 and the 2 weeks, which, everyone, we all agree is so clever, that was done in the original version of the vaccine. And for various immunological reasons, many people thought, okay, that original one maybe would be better than the new recombinant ones we're using. Fortunately, there have now been a number of follow-up studies with the recombinant ones that we're now using, and shows the effect seems to be exactly the same. Some people actually show it's a little bit better. So the good news is the vaccines that we're currently using are a great choice for that.
A couple of other questions. So one, you talked a little bit about well, maybe it'll protect you against shingles for a fairly long time, but not necessarily, maybe there'll be some reduction in the protective effects. So if you had shingles vaccine sort of more than 10 years ago, should you repeat the vaccine?
This question actually is one I need to spend a lot of time with, because mechanistically it's hard for me to understand what's happening there, because the shingles immunity seems to not wane, seems to be protected, and yet the dementia wanes. So does that mean it's the same immune response? Is it a different element of the immune response? Like, what's going on there? And again, that's one study, so we try never to get excited about anything when it's only done once. It does imply, if that is true, that maybe a 10-year boost would be an appropriate way of protecting. And, again, when we look at the cost effectiveness of a vaccine, which is so easy to administer, so cheap compared to other, preventative care and things like that, so challenging. I feel like that would be a good investment, but we really need better data before we're able to change policy to make that the case.
And I guess a lot hinges on trying to better understand what is that protective effect. If it's an adjuvant immune boost, then you could get another vaccine potentially and have the same protective effect. So.
Yeah.
Okay, so a second theme that came up was kind of about the strength and the quality of the science behind it. So I guess you did summarize quite a bit of data, and some of it were, some older studies, some are newer. If you had to, and I think you also highlighted some of the challenges in studying a condition like dementia that you might have to follow people for years. How would you kind of characterize, I guess, the strength of the evidence around vaccines and their ability to reduce dementia?
Yeah, this is really challenging, because oftentimes we think of the randomized control trial as the absolute best way to get good quality evidence, multi-center all over the world. We do it in different populations. Extremely hard to do in this kind of work for two reasons. One, it is recommended that everyone should get their vaccinations. So, if people choose not to get vaccinated, we can sort of do a natural experiment comparing the two groups, but hard to randomize people and then leave them unvaccinated for the 10, 15, 20 years it might take for them to get dementia. So with that caveat, it's unlikely to me that we will get that kind of data in these studies for those reasons. So the second best are these sort of what they call natural experiments, like the week apart experiments, because you can control really well for like the people are not fundamentally different if they're born a week apart. And that data I'm really comfortable with, because now we've seen replication in other populations. So, one thing you always want to make sure is that, if, especially this data that uses electronic medical records and health systems, does one country document things differently than another country? Are there any confounders? But the fact that we're now seeing that same study or types of studies like that being replicated in multiple populations, and with big enough numbers that we can look at men and women or people from different ethnicities or geographies or things like that, I feel pretty confident that the data is strong. And just to summarize, those are the studies showing that shingles vaccination seems to protect against dementia. Where there's still, I think, a little bit of room for clarification is the sex difference, where a lot of these studies, some of them find the protective effect is only in women, some of them find it's more in women, but also in men, and some of them don't find the differences to be that large. It's quite interesting. The other vaccines are a little bit harder to study. Influenza has been around for a long time, so it's harder to find, populations that are not, especially the over 65 crowd, who about 73% of Canadians do get vaccinated, and the ones who don't are actually tend to be less engaged in healthcare, and there tends to be things that make those kind of things difficult. So this is a classic example of how we have to compile evidence from different sources and then understand mechanisms and some of these other things to help make an informed decision or informed policy without having that randomized controlled trial. So I'm most confident in the shingles vaccine. I am reasonably confident with the influenza vaccine. I suspect that RSV and pneumonia are going to follow suit. The other ones, the diphtheria, the BCG, those ones are a little bit harder because it's just more difficult to do those on a population level.
I think it's also probably fair to say for some of the more recent cohort studies, they do a better job of, identifying other risk factors in them. I shout out to our colleagues with the Canadian Longitudinal Study on Age. They are accounting for whether people have hypertension, high blood
Yeah,
pressure, cholesterol. So I think that is also reassuring. It may not be an RCT, but I think people are controlling for other risk factors well.
yeah, I agree.
So, sort of related to this, people are curious about which types of dementia
Mm.
we might be talking about. Do these vaccines appear to mostly reduce the risk of Alzheimer's or all forms of dementia? Because dementia, there's really hundreds of
Mhm,
diseases that may
mhm.
cause dementia, Alzheimer's being the most common cause.
Yeah, so most of this it depends. So different, and it's also complicated because different countries have different ways of coding for dementia in some of these studies. So that also adds as particularly a nuanced view. In general, when they break down by different kinds of dementia, the relative protection differs a little bit, but it seems to be universally.
Hmm.
Some of them don't break down. Some of them just use dementia as any kind of dementia. And so that's a little bit more challenging. And there's it it brings some interesting like mechanistic questions about that. In general, having higher than age average levels of inflammation or having high inflammation in midlife is associated with increased risk of all these different dementias too. So I think when we tease apart all the things, the genetics, the environmental, the psychosocial, the immune aspect of it, I think the immune aspect may be sort of consistent among many types of dementia, and that's what we're really modifying, whereas some of those other risk factors are a little bit more
Mhm.
heterogeneous for different kinds of dementia. But then again, I'm an immunologist, not an expert in I'm not a neurologist.
Yeah, no, I think that's very true in terms of like the evolving understanding
Mhm.
around the mechanisms for many of the dementias, the appreciation of the inflammatory component, and that many dementias may have a mixed element, like Alzheimer's and vascular, possibly with inflammatory components. Um, this is kind of adjacent to it, but trying to understand more and kind of fascinating, I guess, around the inflammation. Do we think the benefit of the vaccines might be mainly from preventing serious infections and possibly delirium? Certainly in the hospital
Yeah.
setting, we see a lot of patients with pneumonia, even urinary tract infections where, they get delirious. Or do you think the changes in inflammation and the immune system, maybe dampening down this chronic inflammation, seem to be more likely to be the mechanism?
I feel like the data is stronger for preventing infections, which have this inflammation and or delirium as a result for it. I feel like the data is stronger. I have a really hard time reconciling how the BCG vaccine for bladder
Hmm.
cancer would fit into that story. So, with all things, multiple things are probably true at the same time. But I think because the best data is for these shingles, influenza, pneumonia, I think it's preventing the infection, or in the case of shingles, preventing the reactivation, which prevents the inflammation, which prevents, has this brain harming effect in late life. I feel like that's the most reasonable explanation, but I'm also completely agnostic, and this is one of the reasons that we have jobs is to figure this stuff out. And one of the reasons we're trying to build these mouse models so we can sort of manipulate things and try to figure out really truly what the source of that is.
One of the questions that came in from a few different folks was talking about, well, what about other inflammatory conditions? So, rheumatoid arthritis, osteoarthritis, possibly, diabetes. Is there a relationship between those other conditions which might predispose to inflammation or infection and dementia risk?
Yeah. So one of the things, I mean, diabetes has always been associated with not only getting more hot infections, but like worse and ending up in the hospital too. So then it becomes hard to tease apart is the extra benefit that's sometimes seen in people with diabetes. Is it because they're just more likely to get really, really sick? So it's especially important for them to get vaccinated to reduce that risk. Or is there some other pathophysiology thing going on there? And you know what? Certainly, the epidemiology of many chronic inflammatory conditions is often many of them are associated with increased risk of dementia, and so is inflammation sort of the underlying root cause, or are there other factors that are that underlying root cause to those things? And I don't have the stats on the epidemiology of osteo or rheumatoid arthritis, but one of the most problematic word in the immunologist lexicon is the word inflammation, because we use it as a very general term, but if you line up 10 immunologists, you'll get 10 different definitions, and they're not all the same. So for example, the inflammation that's associated with asthma in the lungs is not really associated with dementia at all. It's an inflammation, but it's not really associated with dementia or all these things. The inflammation that's sort of associated with some of the cardio risk factors is the same between infections and that. So it's really hard to tease apart all these different inflammatory conditions and their relative risk and whether infections are more or less problematic. And then, of course, it gets more complicated too, because if you have rheumatoid arthritis, for example, you may be on a disease-modifying drug or an anti-inflammatory, which increases your infection risk. So it may be especially important for you to get vaccinated to stop that infection and then have these downstream effects.
Well, I'm cognizant of time, but I think this is an interesting question to kind of wrap up on. You talked about the importance of vaccines, especially this flu season, which is quite impressive already. Given the sort of current atmosphere that still is a bit politicized, there's vaccine hesitancy and refusal. What suggestions do you have for maybe families when they're talking with, friends, older adults about vaccines and some of these potential additional benefits around brain health?
Yeah, I mean, my worry is it sounds too good to be true, right? So if I'm like, oh, get a shingles vaccine, it'll cut down your dementia risk by 20%. That really doesn't make sense to most people when you tell it out of context. So one of the reasons I was so happy to be here today is these longer conversations help people understand the science, and then you can do a better job advocating and explaining to people. So I think, for me, ultimately, dementia in particular is one of the scariest parts of aging, and I would do anything that would decrease my risk even this much. And I would want that for someone I loved or care about, to, even if it was just a small reduction in risk, at least we'd be doing something around that. So I think, to me, that's the most sort of emotive part of this. But I agree, these conversations are difficult. They're long, and they're often against a brick wall. So you really have to have a lot of time to have those conversations. And I always say my job is to listen in those difficult conversations more than I talk, so I can really understand people's perspectives and their concerns, and try to provide like really high quality information when we're able to.
Well, on that note, I want to thank you so much, and for your advocacy as well as advocacy for the portal. I'm just going to close with for those of you who are less familiar with the McMaster Optimal Aging portal, this is a free source of healthy aging information that you can trust. You can subscribe to our free weekly email alerts and get any updated evidence in your inbox, be made aware of special events like our webinars. We also continuously update blog posts and evidence summaries and e-learning based on new evidence that comes out. We have enhanced content or e-learning as well as video posts that are available as well, including e-learning on how to promote brain health, reduce your risk of dementia, understanding dementia. So we have quite a lot of content on cognitive impairment. And to Dawn's point, the latest research considers that people could reduce their risk of dementia by up to 45% with modifiable lifestyle factors, and that wasn't even including some of the more recent evidence around vaccines, so it might be higher than 45%. There's also a micro learning if you prefer receiving content via email. There's a number of series around different topics on that front as well. So this webinar and our other webinars are also recorded. They'll be shared through the Alumni Association's YouTube channel. They're also available through the Portal's YouTube channel if you like video-based content as well. So with that, I really want to thank Dawn for joining us this evening. Thank you all so much, and we really appreciate you joining us.